In rural Texas, navigating behavioral health care can often feel like hiking a complex set of trails. The landscape is beautiful, but it also presents significant dangers. Underfunded systems, overworked providers, and the pervasive sense of isolation. More than 60% of rural counties in Texas are designated by HRSA as behavioral health provider shortage areas. This is more than just a matter of service gaps. It represents a challenge to equity and well-being for most underserved communities. For providers, dilemmas may arise related to too many patients and not enough time. The emotional toll of working with patients who have deep histories of trauma, complex family dynamics, and co-occurring disorders often leads to secondary traumatic stress, vicarious trauma, compassion fatigue, and moral injury. This can contribute to provider burnout, potentially leaving communities with even fewer behavioral health professionals to fill the gaps. For patients, the struggles are equally profound. 30% of Texans needed counseling reported not having access to services. In rural areas, barriers such as transportation, cost, and the lack of local providers further hinder the ability of individuals and families to receive timely care. This lack of access is further complicated by stigma, family dynamics, bias, and fear of judgment from others in the community. These factors work in tandem to prevent many from stepping forward, even if they are ready for treatment. Yet, despite these challenges, rural communities exhibit resilience, and when provided access to innovative and community-led resources, many individuals are ready and willing to engage in services. Evidence-based frameworks can offer pathways to reimagine service delivery models in rural settings. Trauma-informed care helps increase our understanding of the prevalence of trauma, particularly for communities that have been marginalized and under-resourced, such as areas across rural Texas. TIC helps to foster environments where individuals feel safe, empowered, and supported. It helps professionals from all disciplines to focus and shift it to asking what is wrong with this person to what happened to them. We typically think patient-centered, but we also can consider this as human-centered. Human-centered design emphasizes designing solutions with the community, not for them, through collaborative problem-solving techniques such as interviews, observations, and focus groups. And these frameworks encourage a team-based approach that also builds the capacity of community health workers and peer support specialists, all with direct experiential expertise to deliver services in more accessible and culturally appropriate ways. Robert Putnam's book, Bowling Alone, reminds us of the importance of connection and participation in local activities and shared civic engagement. These activities are a source of strength and serve to prevent feelings of isolation and to build resilience. When we go outside the four walls of our organization, we can bowl together with FQHCs, Be Well Texas, CPAN, PeriPan, and TChat, and provide our peer support through ConferMed and the Maven Project. In rural Texas, these community spaces can be the foundation for innovative behavioral health interventions, providing support that is grounded in culture and locally driven. By leveraging community strengths and acknowledging the realities of rural behavioral health shortages, embracing evidence-based frameworks such as trauma-informed care and human-centered design, we have the potential to transform the landscape of rural mental health. We must be ready to traverse complexity, rethink our teams, and engage in communities in ways that build resilience and foster healing.
Hi, I'm Dr. Mercedes Ingram. I'm the Senior Director for the Mental Wellness Institute of University Health in San Antonio, Texas. I work directly with behavioral health programs to be integrated into our health system and the community. One of the most significant challenges preventing rural communities from receiving behavioral health care is a lack of professionals providing behavioral health services in rural areas. Challenges to accessing behavioral health services in rural areas can include long travel distances, transportation issues, a lack of health insurance covering behavioral health issues, social stigma around receiving behavioral health services, and reimbursement issues. In rural areas where behavioral health and primary care clinicians are in short supply, integration of behavioral health and primary care is vitally important. Integrating these services maximizes the use of scarce rural health resources, and it can improve the quality of care for patients and families. The integration of these services can help to reduce the effects of social stigma associated with behavioral health as the services are provided in primary care locations. It is assumed that by placing behavioral health clinicians who are trained to work as part of a primary care team, particularly in rural communities, there will be an increase in the quantity of care and quality of care through enhanced coordination services. Training clinical mental health counseling students in the primary care behavioral health or PCBH consultation model can help improve access to care issues in rural communities. By placing these counseling students in rural internship locations, we are able to then expose the learners to rural healthcare services, increasing the likelihood of rural healthcare practices after graduation. Partners, including the University of Texas at San Antonio, the University of Texas Health Science Center at San Antonio, and University Health came together to write a behavioral health workforce education and training grant federally funded through the U.S. Health Resources and Service Administration, or HRSA. Initially, it was funded in 2017 for 4 years as the Program for Integrated Training of Counselors in Behavioral Health Care, or PITCH. It was successfully refunded in 2021 for another 4 years, and we implemented as the PITCH expanded providers. We included clinical mental health counseling students, school counseling students, social work students, and psychology residents. In both programs, PITCH and PITCH Expanded Providers Program, we were able to include rural internship locations surrounding San Antonio. This really had limited to no previous behavioral health services in the primary care locations. Many of the counties had no behavioral health services at all. So part of the training, we had 2 behavioral health electives, training on behavioral health primary care interventions, skills, and strategies, and 2 internship rotations for the clinical mental health counseling students. We had 4 site supervisor trainings, since many supervisors that are clinically oriented behavioral health have never worked in primary care. And semesterly, we had site visits at these rural health care locations by a behavioral health consultant. Additionally, we had 4 interprofessional workshops that included the clinical mental health counseling students, school counseling students, social work students, and psychology residents to really get them to learn the skills of working together and how they can do their own work at a separate site and then come together to share how they can best provide patients care. Overall, this really helped us increase knowledge in interprofessional teamwork, clinical practice, primary care context, and intervention design and delivery, and outcome-based practices. Primary care providers really expressed that it improved access and availability of these behavioral health services in their rural locations. And currently we have 115 graduates, all have trained in over 36,000 hours of pro bono behavioral health care services. For more information about our program and what primary care behavioral health consultation model can do for you, please scan the QR code below. Thanks.
Hi, I'm Dr. Tara Haskins, and I'm pleased to be here today to share with you the work with AgriSafe. AgriSafe is a national nonprofit. We've been around for about 23 years. We excel in the space of both virtual and face-to-face educational trainings for healthcare professionals that care for people that work in ag, as well as the people that are doing the hard work themselves. We pride ourselves in that we try to maintain a culture of readiness so that we can respond to emerging health threats and issues that impact our ag workforce. We don't do it in a vacuum. We rely on our partners in NIAS centers, Ag Extension, federal organizations and agencies such as the CDC, USDA, and NIH, as well as the academic professionals that do a lot of the research in this space. On the right-hand side, you see our Total Farmer Health model. We are an affiliate of Total Worker Health, and this is our model that depicts what we feel like are the major buckets that impact the health and safety of ag workers and their families. The ag family is in the center. 90% of U.S. farms are family-owned farms, and so it's important that we address their health both at work and in their own personal lives. And so you can see that some of the icons are very distinctive for agricultural work, such as weather, finances, sleep, access to health care, and the inherent hazards that exist in that workforce. I can't do today's talk without talking just a little bit about agricultural mental health. The occupational group, ag, forestry, fishing, and hunting, has the fourth highest rates of suicide. There are a lot of factors that impact that. In addition to that, if we break that occupational group down into occupational roles, the male agricultural managers, as we understand as producers, those people making the daily decisions, have even a higher rate of suicide. Certainly that, coupled with the fact that these individuals live in rural communities and they also have greater access to firearms, increases the risk of death by suicide for those individuals in crisis. Our ag communities tell us that stigma is certainly improving with all the hard work that's being done across the nation, but it's still a factor and needs to be addressed. They also say that they're more willing to talk to people about their mental health, but they are certainly experiencing more stress than ever. These are just some of the topics that AgriSafe tries to address: exposures to chemicals, inherent dangers working with livestock. On the right-hand side, you see some of those emerging threats that we see: foreign animal disease and disaster, floods. And we also try to provide education and training that help individuals on topics such as the aging farmer. The current average age of a farmer is over 58 years old, and a large proportion of that workforce is in their 60s, 70s, and some in the 80s. So these topics are really important, and they certainly are a holistic approach to health in this occupational workforce. AgriSafe has a very deep well of resources on our website. You can come and look at those. We provide free webinars and resources that are printable. We have a very extensive holding of trainings that address suicide, which include QPR for ag communities, CALM, which is Conversations on Access to Lethal Means, and also access to naloxone within the workforce. Our farm response training is specific to healthcare professionals. Really important to educate those individuals, and those individuals that take farm response and provide direct behavioral health care can join our AgriStress provider directory so individuals can search for a provider that understands them. Our AgriStress helpline is one of our services that we directly provide to producers and their families in the workforce, and that's a 24/7 suicide crisis line that provides ag resources as well as suicide crisis emotional support and mental health resources. Those crisis specialists also use the AgriStress provider directory to connect people working in ag to providers that they need to help them through their crisis. Thank you, and I look forward to your questions.
Hello, I am Lieutenant Jalima Calker with the Substance Abuse and Mental Health Services Administration. I am a social science analyst on the evidence-based practices team with SAMHSA's National Mental Health and Substance Use Policy Laboratory. I am here to share with you just a few resources that we have that support our rural communities. First, we have our Evidence-Based Practices Resource Center, EBPRC. The EBPRC was established in 2018 to fulfill the requirements of the 21st Century Cures Act. The EBPRC is a comprehensive online resource center that provides communities, clinicians, policymakers, and others with information and tools to incorporate evidence-based practices into their work. It includes a collection of scientifically based resources, such as treatment improvement protocols, toolkits, resource guides, climate practice guidelines, and much more. The EBPRC aims to improve access to reliable and valid information on evidence-based practices and programs, ultimately supporting better behavioral health outcomes nationwide. By providing high-quality resources and tools, the EBPRC helps bridge the gap between research and practice, ensuring that communities and practitioners have the information they need to make informed decisions. The EBPRC is accessible online, and its resources can be searched by topic area, substance or condition, resource type, target population, and target audience. The EBPRC resources are disseminated through various channels, including webinars, social media platforms, email blasts, online forums, and partnerships with professional organizations to reach a wide audience. The EBPRC enhances rural resilience by providing actionable resources and tools to address the intersection of climate change, behavioral health, and workforce development, supporting rural communities' ability to mitigate, adapt, and recover from climate-related stressors, promote behavioral health equity, and foster a resilient workforce. Next, we have our Rural Opioid Technical Assistance Regional Center Program, ROTA-R. The purpose of the ROTA-R is to develop and disseminate training and technical assistance addressing opioid and stimulant use affecting rural communities. The ROTA-R teams are expected to facilitate the identification of model programs, develop and update materials related to the prevention, harm reduction, treatment, and recovery activities for opioid use disorders and/or stimulant use disorders, and ensure that high-quality training is provided. The ROTA-R program is comprised of 10 regional centers, with one located in each of the 10 Health and Human Services regions. Our next program is our Rural Emergency Medical Services Training Grant, Rural EMS. And the purpose of this grant is to recruit and train EMS personnel in rural areas with a particular focus on addressing substance use disorders and co-occurring disorders and substance use and mental disorders. SAMHSA recognizes the great need for emergency services in rural areas and the critical role EMS personnel serve across the country. By doing so, we provide funding to support training of EMS personnel on substance use disorders and co-occurring disorders, trauma-informed, recovery-based care for people with such disorders in emergency situations, and as appropriate, to maintain licenses and certifications relevant to serve in an EMS agency. With this, we aim to develop the capacity of EMS staff to support residents in rural communities. These are only a few of the many resources SAMHSA has that support our rural communities. To find out more information, please scan any of the QR codes and visit our websites to explore what more information and resources SAMHSA has to support our rural communities. Thank you.